just a little bit about myself and my background. So I grew up very closely with my grandparents, who were both Italian immigrants. And pictured here is my Nana Rose and myself when I was growing up in Texas. And some of my earliest memories were spending time alongside my Nana Rose, who was a very, very vibrant woman, who was an Italian immigrant, as she would roll out homemade pasta and smelling the aroma of homemade spaghetti sauce and gravy in our home each week. And as I grew up and aged, my grandparents and my Nana Rose in particular aged alongside with me. And one of the most profound changes that occurred somewhat suddenly that me and my family noticed in her was an abrupt change in her ability to move very smoothly. She began dropping more items, as well as changes in her memory and thinking, and increased anxiety. And so this was a very profound change that occurred somewhat suddenly for her over several months. And it was only until we saw a neurologist in our hometown that he was able to provide a diagnosis to my grandmother and to speak with our family. And I remember to this day him holding my grandmother's hand and talking with our family and explain the diagnosis of Parkinson's disease, dementia, which she had. And initially there were treatments that were available that helped to slow the progression of this illness. But as we know, the current treatments that are available for Parkinson's disease, for Alzheimer's disease, are really limited in terms of they may slow the progression, but don't ultimately halt the disease from becoming more severe and taking on more severe symptoms for patients that are distressing. And this indeed happened to my grandmother. So this motivated me that experience motivated me to become a physician like the neurologist, who was able to be with my Nana Rose and my family at our time of greatest need, and a very frightening time for all of us. And also to be a medical researcher in the Harvard Aging Brain Study and similar studies, where we not only provide compassionate care for patients, but we advance knowledge. So we work towards developing new treatments that could prolong life and prolong quality of life for patients and their families. So also a little bit about myself. My experiences that I just described took place in Texas, where I very early began to investigate mechanisms of disease and brain illnesses such as Parkinson's disease and Alzheimer's disease and related degenerative conditions in mouse models shown here, very basic levels of cells and proteins. And also as part of my experience became very invested in Texas foods and sports, and but transitioned over the past decade to Massachusetts, where I integrated this knowledge of science with training in medicine as a geriatric psychiatrist. And with that transition occurred a change in some of my allegiances in terms of both food interests and some sports teams as well. So again, I'm very interested in the process of changes in the aging brain that relate to not only memory and thinking, but also to behavior such as anxiety and depression. And I have investigated this at the level of molecules and cells, then looking more broadly at how are these cells connected, how are neuronal pathways changed in disease. And then finally, most recently, what I'll tell you about today, through some of the work in the Harvard Aging Brain Study and the MOMENT study, due to data that you all have contributed, thinking about the level of patients, how can we correlate, and individuals in the community who are healthy older adults, how can we correlate clinical symptoms, behaviors, observations of patients and their family with changes in the brain that we can visualize through neuroimaging studies. So that's been a little bit about my professional and personal journey. And then I'll tell you a little bit more about the topic that we've been focusing on in the Harvard Aging Brain Study and in the MOMENT study related to this level of clinical research investigation. So as we all know, and as you probably heard of through this Food for Thought and other series, that prevention of Alzheimer's disease and related dementias is a public health priority, given that today alone in America, nearly 6 million Americans are living with Alzheimer's disease. That's not taking into account the more than 16 million who are serving as unpaid caregivers or supporters for patients with dementia. And these numbers are expecting to increase by the year 2050 if we don't develop more effective ways to prevent or Alzheimer's disease or delay its onset. And just to think broadly for a second, we say Alzheimer's disease and dementia. And just to clarify that point here, so when we think of dementia, we think of this as a clinical syndrome that is characterized by loss of memory or other thinking changes due to underlying changes in the brain. At the stage of dementia, it's severe enough to interfere with daily living activities. Now, dementia is an umbrella term used to describe this degree of change in memory and thinking that interferes with activities of living. And as you can see here on this slide, there are many different causes. There are many different types of brain changes that can give rise to dementia. Alzheimer's disease being the most common, as well as vascular disease, Lewy body dementia, and frontal temporal dementia, as well as mixed or combination of these types of dementias. And importantly, many memory disorders may not be due to dementia, and they may be due to reversible causes or causes that could partially be reversed if they are identified and treated. Now, as I mentioned, Alzheimer's disease is the most common cause of dementia, and it is characterized by a distinct clinical presentation where patients may have difficulty in remembering newly learned information as a very early symptom. Now, other early symptoms that we're beginning to recognize increasingly are changes in orientation, as well as changes in mood and behavior. And this may progress to more severe confusion, disorientation, and more serious memory loss. And in terms of the brain-based changes that characterize Alzheimer's disease, these are visualized in this pathology specimen where we're actually able to look at proteins in the brain in a postmortem sample of a patient who had probable Alzheimer's disease. And this was confirmed at the time of autopsy, where we see hallmarks of pathology, including amyloid, here, extracellular amyloid plaques, as well as intracellular tangles comprised of tau protein. So amyloid and tau protein being the hallmarks of Alzheimer's disease, but there are also other changes that are occurring in cells that we can measure, including inflammation and changes in cellular metabolism. When we talk about biomarkers, and so the Harvard Aging Brain Study and the MOMENT study are studies where we are investigating changes in biomarkers. So that is things that we can reliably measure and detect that indicate the presence of a disease process. And they can help us to distinguish whether or not this brain-based change may be due to Alzheimer's disease or another cause. And they are important both in research studies like the ones that you're participating in, and also emergingly as we're able to be more reliably investigate biomarkers and measure them and correlate them with clinical outcomes and prognosis, they will become increasingly important in the doctor's office and probably in future clinical care as we develop more information about biomarkers. So one particular, or two, I should say, two biomarkers that I mentioned for Alzheimer's disease are amyloid and tau proteins. And with the advancing neuroimaging technologies, and specifically PET imaging technologies, which many of you on the call have participated in, many if not all of you have participated in through the Harvard Aging Brain Study or the MOMENT study or related studies, this allows us to visualize in living individuals and measure levels of amyloid shown in the top panel and tau shown in the bottom panel in the brain, and correlate this with not only changes in memory and thinking, but also symptoms of mood, anxiety, or other behavioral changes. And so now also emerging technologies allowing us to detect these biomarkers also in blood or fluid samples from the body. And so this is emerging and may also allow us to visualize amyloid, tau, or other changes in living individuals so we may correlate with their memory and thinking and behavior. Now, with the advent of biomarkers and our ability to visualize these in living individuals through neuroimaging, and then more recently through measurements in the blood or in the spinal fluid, this has allowed the field to recognize that Alzheimer's disease progresses through a series of stages. So I talked about the syndrome of dementia, Alzheimer's disease dementia, but we now recognize that actually, changes, brain-based changes related to amyloid and tau accumulation occur in what we call the preclinical stage of Alzheimer's disease. So in this stage, individuals don't have profound deficits in memory or thinking, but they do have evidence of elevated amyloid protein in their brain and spinal fluid. But again, they don't have memory impairment, where we would consider it a memory disorder. So we're now recognizing that the process of Alzheimer's disease and related degenerative illnesses likely begin for decades, where we may see buildup of proteins like amyloid. And that comes before the stages of mild cognitive impairment or dementia. And we've been able to recognize this through imaging technologies like PET imaging technology, which allow us to measure biomarkers throughout the life course. Now, what about depression and anxiety symptoms? So I mentioned that this was a really important part of my personal journey in terms of what I observed in my grandmother, what my family experienced when I was growing up. And it's also continued to be something that I observe as a geriatric psychiatrist, and noting that depressive and anxiety symptoms can be common in older adults. And as individuals have also progressed to Alzheimer's disease dementia, neuropsychiatric disturbances or symptoms of a wide range can be common, ranging from mood and anxiety to irritability, agitation, even aggression, so even later stages of Alzheimer's disease to elements of paranoia, hallucinatory experiences, and changes in sleep and appetite. As we are measuring, you're able to measure and capture early behavioral and memory changes in individuals, we're recognizing increasingly that depressive anxiety and other neurobehavioral symptoms may actually be among the early manifestations of preclinical Alzheimer's disease and preclinical stages of other dementia syndromes. So not only maybe our subtle memory complaints or worries, early symptoms, but also feelings of distress, emotional distress may also be early manifestations or early signs of these disorders. And so late life depressive symptoms, as I mentioned, can be quite common in older adults. The biology of these symptoms is poorly understood. And through our work and the work of other groups internationally, it's been recognized that in some individuals, these symptoms, not all, but in some individuals, these symptoms may be a prodrome or early stage or risk factor for Alzheimer's disease, dementia, or another dementia. Now, again, a number of changes occur in midlife, in late life, and indeed, these changes are more profound in our current climate today, given the pandemic that we're experiencing. And these can include things like work transitions, relocation, loss and grief, changes in physical activity. And despite these changes that may occur in mid to late life, depressive symptoms are not a normal part of aging. So it's not the case that we expect as we all age that even though we encounter these transitions, we will become depressed. But these can sometimes serve as triggers, environmental triggers, combined with biology that could lead to depression or anxiety. And the question is, in some individuals, may these symptoms be associated with greater risk of Alzheimer's pathology? And how can we identify that? And if that's the case, how can we intervene in those individuals who are at risk? And this is basically just reiterating what I said here about the somewhat complex relationship between depression and neuropsychiatric symptoms in dementia. That depression may be a risk factor or a prodrome for dementia, maybe an early presenting symptom. In some cases, in many cases, depression may exist or anxiety may exist, but they don't mean that the individual has dementia or will get dementia. But individuals may have complaints of memory and thinking. And then also at the stage of dementia. So if individuals do progress to a stage of dementia, these symptoms can also be common and can be associated with greater distress of the patient and caregiver. So in working to better understand the relationship of these early neuropsychiatric symptoms and brain pathology and Alzheimer's disease, this has several clinical implications that I've alluded to. But just to highlight these here, this may allow us to identify the earliest changes in individuals that might provide a window of opportunity to introduce an intervention. To identify individuals who may have the highest risk of subsequent decline, so we could target those individuals for interventions, and to allow us to develop more effective prevention and treatment measures for depression and memory decline. So motivated by those end goals, the central questions in the research that we've been pursuing in the Harvard Aging Brain Study and in the MOMENT study and related studies include the following. So our late life depressive symptoms associated with Alzheimer's disease pathological changes in the brain. And this can include even very mild depressive symptoms, or do we see an association with pathological changes? And further, what are the relationships between depressive symptoms, pathological changes, and memory and thinking? And are there particular symptoms or particular expressions of emotional distress that are associated with pathology and memory decline? So these are the central questions that we have been, that myself and co-investigators in the Harvard Aging Brain Study and MOMENT study have been investigating and continue to investigate with your critical participation in these studies. So this is a very relevant question because the prevalence of late life depression itself ranges from anywhere from 15 to 40% in terms of mild to more severe symptoms. So it's a highly prevalent condition. And just to give you a snapshot of what we found through work in the Harvard Aging Brain Study, and what I'm going to be showing you here are all results that have come from analysis of data contributed over a 10-year span in the Harvard Aging Brain Study. So first, we asked what is the relationship between depression and tau protein in the brain? And so we took a snapshot at a single time point in the Harvard Aging Brain Study, and we saw that higher depression was associated with higher tau, which you can visualize on this PET scan here. As the study has progressed, due to your participation, we've collected data over several years in the study. And so we wanted to ask, what is the relationship over time between depression and memory and thinking changes when we take into account levels of brain amyloid? And so these are PET scans where we measured brain amyloid using PIB, a tracer that binds amyloid in the brain. So what we found here, we found this inverse relationship. So greater depression went with worse memory abilities on memory and thinking tests, but this was modulated by levels of amyloid, as you can see here. So at low levels of amyloid in the brain, and we don't see a very strong relationship between memory and depression. But as levels of brain amyloid increase, we see this inverse relationship, that is, greater reports of depressive symptoms are associated with worse memory performance on tests of memory and thinking. I just want to again highlight that this data has come from your participation in the Harvard Aging Brain Study, and given that at the study entry and throughout the study, and this is a study of healthy aging, so reports of depressive symptoms and memory changes are often mild in the study, especially at the stages in which we carried out these investigations. So we're seeing this relationship even at very mild reports of emotional change or memory and thinking change. So I just wanted to highlight that as well. Over time in the study, we also wanted to ask, what is the relationship between tau protein and subsequent change in depression over time? So here we've asked you in the study if you had a depression history, and individuals have reported that they either had no depression history, a recent history of depression, or a remote history of depression that may have started earlier in their life. Then we looked at the course of depression, shown here in these lines, related to tau protein. So we found that if someone reported no depression history, they generally started with a low depression score in the study, versus if they reported a recent or remote depression history, their depression level started at a little bit higher. Interestingly, for all groups, we found that levels of tau, which are shown in highest levels of tau are green, followed by red, followed by blue, that when we have higher levels of tau protein, we see a greater rate of rising depressive symptoms over time, as you can see from 0 to 8 years in the study. Sorry. And again, in this here, we were able to visualize using, putting together a map. This is a visualization of an example, kind of a representative brain. And we show in coloring here the regions where we see this link between increased tau protein and increased rate of depressive symptoms over time. So interestingly, we see this, this association, these areas of lighting up color in regions of the hippocampus, and in the temporal lobe part of the brain, and also a little bit in the frontal lobe. And these are regions that have been implicated in regulating not only memory, but also regulating mood. So this confirms the previous slide that I showed you, where we see increased tau leading to increased rate of depressive symptoms over time in regions of the brain that we would expect these changes to be, in which we would expect these changes to occur. As you know, we also, in the Harvard Aging Brain Study, there are many, in the moment study, there are many types of neuroimaging that you complete, including PET neuroimaging, and I've showed you results for amyloid and tau PET in the previous slides. And also, a part of the study involves MRI scans, where you go into the MRI scanner at Charlestown Navy Yard. And we able to measure structure of the brain, and we're able to measure through those scans, we're able to measure levels of cortical thickness. So how thick is the cortex? Is there evidence of thinning of the cortex in any region? And here we wanted to ask, can we associate how thick the cortex is with the rate of rising depressive symptoms over time? And these are preliminary results of analysis that was carried out by Pranitha Pranath, who is an outstanding research assistant in the Harvard Aging Brain Study in the Moment study, who many of you may have worked with or will work with. And so here she found, and in levels of blue, here we also, in these temporal lobe and hippocampal regions, we see this relationship between decreased cortical thickness, so signs of neuronal degeneration or neuronal loss of integrity, and increased depressive symptoms over time. And we also see kind of the opposite pattern in frontal regions of the brain. So this was very interesting to us, and in combined tells us that even at low levels or low reports of emotional distress, we see correlations with brain-based changes, including tau in the brain, levels of cortical thickness, as well as amyloid. So in conclusion, from all of these studies together, we have found that depression, amyloid, and cognition seem to be closely related over time in older adults who don't have dementia, so who are cognitively unimpaired older adults. And tau and neurodegeneration, the cortical thickness measurement that I told you about, seem to be independently associated with increasing depressive symptoms over time. Together, this is an area that we're really interested in further pursuing, and they support the fact that that depressive symptoms or other emotional symptoms may be targets Alzheimer's trials that are aimed at preventing Alzheimer's disease. As I mentioned, there is a relatively low range of depressive symptoms represented in our study at baseline, and so we'd like to further investigate this in the future in population-based samples as well. And one of the related studies that many of you are participating in, who are on the call, that we've just started in the past few years, in parallel to the Harvard Aging Brain Study, is the Mood and Memory and Aging Study, or MOMENT study. And I just wanted to tell you a little bit about the study. And again, many of you who are on the call are actually in this study, and we thank you for your participation and in getting this study going. It's really one of the first of its kind that is asking the question, actually, in individuals who have been diagnosed with clinical depression in earlier stages of their life, asking the same types of questions. If we carry out measurements of the symptoms that they report of depression with brain pathology over time, do we see relationships between depressive symptoms, amyloid, tau, and atrophy? And do these symptoms modify the relationship between pathology and changes in memory and thinking? And so again, this is really one of the first studies of its kind made possible by you all who are in this study, where we're focusing on individuals who have a diagnosis of depression when they enter the study, and asking these questions between of relationships between depression, memory and thinking, and brain pathology. And again, we've just started this study in the past few years due to your participation, and we're beginning to accumulate, increasing data from brain scans and clinical assessment. So hopefully in a future call, we can share some of those results of what we have found with you all. So future approaches that we're interested in carrying out include what specific symptoms of emotional distress or from the depression scale are associated with pathology changes and with memory and thinking changes. As we all know, symptoms of emotional distress or anxiety can be quite variable from person to person. So are there specific types of symptoms or signs that individuals are noticing or reporting that are driving these links with brain pathology? And furthermore, what about other types of changes in aging that occur in the brain, such as changes in inflammation or in connections between neurons and synapses? Can we measure those through blood samples, and how do those relate to mood and to memory? And finally, as a new kind of area of investigation in the Harvard Aging Brain Study and the MOMENT study and related studies that you may be hearing more and more about, especially as we move to more virtual assessments in this time of increased physical distancing, are kind of remote assessments, or we might ask you remotely on a tablet-based questionnaire or another type of device, how you are, more frequently questions about memory and thinking and mood. And can those allow us to better capture or accurately capture these relationships? So can this type of assessment using technology provide greater sensitivity and provide an alternative way of making these measurements in addition to or to complement in-person visits in the clinic or to the Navy Yard? And finally, as I mentioned, in terms of the clinical implications, where would we like to go with this in general? And what motivates us, in doing this, and what may indeed motivate you all in participating in the studies, is we'd like to have this inform, to utilize this knowledge to inform future prevention and treatment studies. So, for example, can interventions that could target things like exercise, mood, social engagement, depression, anxiety, diet, sleep, can they prevent or slow brain changes in aging, prevent or slow changes in memory and thinking? So ultimately, we hope to further build on the program that I've described to you, and and introduce intervention or prevention of approaches or prevention research studies. Even before we think about those types of intervention studies, or where we're suggesting a formal intervention for individuals to carry out, there are ways that we can think about better mental well-being and boosting brain health and boosting mental health. And I see the slide is expanding there. I'm not exactly sure why, but I have another slide that captures some take-home points about ways to think about this. And indeed, it is challenging, especially during this time of greater societal stress and during the pandemic that we've all been encountering. But as this acronym is a way to kind of think about ways to shield the brain, to promote brain health and mental health, you might think of the acronym SHIELD in terms of trying to preserve sleep, as well as one can thinking about stress levels, what works for you when stress comes up, such as we're all facing, interactions with others, socialization, physical activity, getting some steps in each day, getting some, mental exercise or flexing the mental muscle, if you will, in terms of learning new things, or even just taking a different path home on a walk would be a way to think about that. And also diet. How do we nourish our bodies? How do we nourish our brain? So thinking about what really is protective for our heart and lungs. The same blood vessels that are feeding those organs in our body are also feeding our brains. So when we think about maintaining a healthy diet, decreasing smoking, eating more vegetables, less saturated fats, less processed food, that also can preserve our heart health, our body health, but also our memory health and also our mood health. We're finding as well. So just thinking about shields. Again, it can be challenging to practice this during, especially during times of increased societal stress like we're experiencing now, but this is something to kind of keep in mind and to think about, both for yourself and together with your families and groups of friends. And finally, I mentioned how I started on this personal journey and a little bit about my professional journey. And shown here is a picture, again, it was my Nana Rose, and this was very close to the end of her life. And so she ultimately succumbed to Parkinson's disease, dementia. And it is my hope and our hope in the Harvard Aging Brain Study and related studies that we can work to prevent dementia, that we can improve outcomes for individuals like similar to my Nana Rose and to similar families, where we could reduce psychological, physical, and financial stress that are experienced by patients and caregivers at the stage of dementia. And towards this, we are hopeful at MGH to develop a mood and memory clinical research program that can focus on personalized phenotyping, that can focus on prevention, and that can provide support to patients and families. So that is our big picture 5 to 10 year goal, and one that we are passionate about pursuing, about improving experiences of patients and families. That's ultimately, at the end of the day, what we want to do. And that, just to reiterate, a huge thanks to all of you on the call, to participants from HABS, MOMENT, COBOS, all related studies that we are building. A huge thank you. This is just a snapshot of one of our virtual group meetings from HABS and MOMENT. So we've continued to work on the data that I showed you while working remotely, and so we wanted to just give a huge shout out and thank you to all of you. You make the research possible and create hope for the future, for developing the types of programs that I'm describing. So thank you so much again. And I think we have some time for questions.
That's great. And I echo Dr. Gatchel's thanks for you guys' hard work and participation, as well as thank you guys for spending part of your morning with us today. And thank you, Dr. Gatchel, for that fabulous talk. I'd never heard of that SHIELD acronym before. That was fascinating. So just a reminder to everybody, if you'd like to ask Dr. Gatchel a question, you can either type it to us in the chat function if you're on Zoom. If you're on Zoom, you could also raise your hand or type a question into the Q&A bar. So are there any questions?